Welcome back. In the previous lectures, I've described first the challenge of cancer, some statistics and some ideas of cancer spread in populations. Then we talked about the causes of cancer and brought that down to the DNA level. Last lectures, I've described cancer as a disease, ending up at the cell level, and we saw how cells grow and begin to cause a tumor. I want to continue on that by talking about two properties of cancer cells that are rather unusual. One of them is the spread of cancer, called metastasis, and the other is angiogenesis. My story for introducing this topic is a story of Dr. Judah Folkman. Judah Folkman, as he grew up, accompanied his father, a rabbi, on visits to hospital patients and became quite inspired to become a doctor. He was drafted as a physician into the U.S. Navy and did a surgery residency and lab research at the Naval Hospital in Bethesda, Maryland, which is a top place. His research concerned blood and blood substitutes, and in the course of his research, he did a couple of interesting experiments. In the first experiment, he implanted mouse cancer cells into a live mouse. Now, typically, if you do it in a live mouse, like a nude mouse, as I showed you earlier on, the mouse cancer cells will grow gradually into a tumor. And he noticed that they didn't start growing until a couple of days. The tumor, this group of tumor cells just kind of sat there. It was a ball of cells, and a couple of 100,000 cells probably, and it just sat there in the mouse and then took off after a couple of days. It was a lag time. That's his first experiment. In his second experiment, he took cancer cells again, and he did the same experiment, only he did it in a laboratory dish in some isolated tissue from an organ, the thyroid gland. And he put that in the lab, and he waited and waited and waited, and the tumor didn't grow. He puzzled. What is this? What is going on? Why is there a delay in tumor growth in the animal experiment? And what was missing in the thyroid tissue that the tumor wouldn't grow at all? He coined a term for both situations. He called them tumor dormancy. Folkman developed a hypothesis, that is a proposal, and the proposal he was going to test with experiments. His hypothesis was that in order to grow, a tumor, like any organ in the body, needs a blood supply. What does blood do? Blood delivers oxygen through hemoglobin to tissues for energy. It removes waste like carbon dioxide and other wastes. So every cell in the human body has to be pretty close to the blood supply. That's why we have all these capillaries. Typical cell, no more than 5 cell layers away. So a typical cell in the body, it has to be at least 5, at the most, 5 cell layers away from a blood vessel. During development, as organs form in the developing fetus, the blood supply has to be recruited, right? There's a blood vessel nearby, and this organ is developing. The blood vessel is recruited. That process is called angiogenesis. Angiogenesis. Angio is the blood supply. Angiogenesis is the recruitment. Folkman came up with his hypothesis of tumor angiogenesis. He proposed that a tumor just sitting there can't survive for very long and certainly can't grow unless it recruits a blood supply. And he said the tumor must make angiogenic signals and send them to a nearby blood vessel and say, hey, come on, make a branch, move over here. Okay? And then the angiogenic signal will land on the nearby blood vessel. It'll make blood capillaries. The blood capillaries will grow back up to the tumor that's nearby and give it a blood supply, a vascular supply. This could explain his 2 experiments. The first experiment, remember, he put the tumor into the mouse and he waited a couple of days. He figured what was going on during that couple of days was angiogenesis. That small tumor was sending out signals to the blood supply saying, give me a blood supply, give me some capillaries, and then it would grow. In the thyroid experiment, there's no blood there. There's no blood tissue at all, so there's no angiogenesis, so the tumor is just going to sit there and eventually die. Now, Folkman was a surgeon, and he noticed something very relevant to this in surgery as well. In some cases, when he removed the primary tumor, when there was a metastatic tumor that had small metastases around the body, all of a sudden the metastases took off. And sometimes he didn't even know there were metastases there, and all of a sudden when the primary tumor was gone, the metastases took off. What he said was, oh, what's going on here is perhaps the primary tumor sends out an angiogenesis inhibitor, something that causes tumors to be dormant. It prevents them from getting a blood supply. That goes out to the main tumor to block angiogenesis in the metastases. It's kind of like you have the old Western movies where you have a gang in a town, and the gang says, we only, and another new gang comes in town and says, there ain't no room in this town for both gangs. This is a very famous movie called The Magnificent Seven that was on that model. So here's this experiment. There's a large primary tumor, and it inhibits somehow the small metastases from growing, and it does it by blocking their blood supply. So the importance of all of this was, of course, let's harness the natural angiogenesis inhibitor that the large tumor makes, in some cases, not all. Let's see if we can use that to block angiogenesis clinically. And if you block angiogenesis, you'll block tumor growth, you'll block metastases. Or let's understand the basic biology. What is that stuff that the tumor sends out to recruit a blood supply? And maybe we'll work on that as well. So the overall idea was to treat cancer by inducing dormancy. Folkman came up with this idea in the 1970s. And at that time, most doctors thought, no, that's not how metastases work at all. Metastases themselves grow right by the blood supply. They don't need to recruit a blood supply at all. This tumor dormancy is a crazy idea. He had a lot of trouble getting funding. No one believed him at all. It took about 20 years of painstaking research, that's beautiful science, for him to show in both animals and humans that the Folkman idea of angiogenesis was correct. A company was set up to begin to exploit these discoveries. And a famous event kind of in the annals of cancer research and business happened in 1998. In May of 1998, Folkman was at a social event, and so was James Watson, the discoverer of the DNA model of Watson and Crick. And Watson is there, and he gets all excited about what Folkman is doing, because this is amazing science when you think about it. You could make all tumors dormant. And he said very loudly that Dr. Folkman would be remembered along with scientists like Charles Darwin as someone who altered civilization. He's going to cure cancer in 2 years. Well, either beknownst or unbeknownst to Dr. Watson, when he made this statement, it was in the hearing of a leading writer for the New York Times. And the next day, on the headline of the New York Times was, Judah's Folkman's going to cure cancer in 2 years. You can imagine what happened in the stock market to the stock of the company that was developing this, was exploiting this discovery. Entremed stock went crazy the next day and went way up, etc. It went back down later on. So there's a lesson in this, by the way, in terms of medical research, especially in cancer drugs. Don't say anything in public before the discovery has been well ratified. At many scientific meetings, cancer research meetings, there's an embargo at talking to the press before the meeting. The actual angiogenesis inhibitor from the natural system in mice, for example, that was sending out, remember the inhibitor that blocked anti-angiogenesis in mice for metastases, didn't turn out to be the answer. The answer turned out to be studying the natural system. And anti-angiogenesis drugs are now a major discovery in the last decade in fighting cancer. The system has been well worked out. The tumor cell and the receptor in the capillary have been characterized. The signal has been characterized, and a drug is now, and several drugs are now in clinical widespread use clinically successfully to induce tumor dormancy and block angiogenesis. In this lecture, I'm going to describe tumor growth and development. First, I'll describe benign and malignant tumors, then the diagnosis and staging of tumors, and then rapidly growing and growing rapidly or slowly in the tumor's growth. And then, of course, we'll get to metastasis, angiogenesis, and the burden of tumor growth on the body. First, I want to talk about benign and malignant tumors, what the difference between them is. Here are photographs of benign and malignant tumors of the same tissue. A benign tumor increases in size, it grows slowly, and then kind of stops. Benign tumors do not invade other tissues. They don't form metastases. Benign tumors usually have a hard capsule of fibrous tissue that separates them from surrounding tissues. And in benign tumors, the cells of the tumor very often resemble the parent. For example, a lipoma is a tumor of fat cells that's benign, make a little ball of fat cells, and it just sits there and they make fat. Some tumors that are benign make hormones. A tumor of the pituitary gland in the brain might make a whole lot of pituitary-based hormones. Some benign tumors just sit there and they're harmless. For example, I have one right here below my shoulder pad, and that tumor is just sitting there. It's a lipoma. It doesn't get bigger. It's just sitting there. It's no use to do the risk of surgery to take it out. Other benign tumors, though, may make hormones, like I mentioned, and that may cause physiological effects, so you have to take it out. Another benign tumor may block an organ. It may block the kidney, or it may block a tube in the brain, or maybe it may be somewhere else. That has to be removed as well. So sometimes you can just leave benign tumors there. Sometimes you have to take them out for the effects that they're causing. On the other hand, are malignant tumors. Malignant tumors have undifferentiated, not differentiated cells. Malignant tumors can invade metastases as opposed to just sitting there. Malignant tumors don't have a capsule kind of defining the tumor edge. They have a fuzzy edge because they keep growing. Malignant tumors lose all normal arrangement of a tissue, and they have variations of sizes and shapes. Now, a brief introduction to how tumors are named. And the way I'll introduce that, I don't want to give all the names of tumors, etc. It's just to give you a general idea. If you look at a typical tissue lining an organ has on the very exterior, or the part that's right by the organ, in the intestine, for example, closest to the lumen or the space of the intestine, is epithelial. Below the epithelium is what is called mesenchyme. Okay? And in the mesenchyme are things like fat and blood vessels, etc. Okay, first type of tumor I'll describe are epithelial tumors. These are called carcinomas. Epithelial tumors, carcinomas, are 85% of all cancer. They're the ones that line the organs. So, for example, for this outer layer of the skin, you'd have squamous cells that would be called a squamous cell carcinoma. A benign tumor of those same cells that just sits there is called a wart or a papilloma. Below the epithelium is our mesenchyme, and those are called sarcomas. Sarcomas are solid tumors of muscle and bone primarily, and fat as well. They account for about 5% at the most of all tumors. So 85% carcinomas, about 5% mesenchymal-based sarcomas. So example of mesenchymal tumor would be liposarcoma, a malignant tumor of fat cells. The benign one I mentioned is lipoma. Then we have tumors of the blood, which account for about 9% of all tumors. And that's leukemia or lymphoma of white blood cells. And the lymphoma ones come from white blood cells and lymph nodes. We'll talk about that later on. These are the blood cancers, about 9%. 1% of tumors, I mentioned in the last lecture, are teratomas, these tumors that differentiate and redifferentiate organs and can have all these crazy things going on in the tumor, like hair and teeth, etc. Of course, there are some special names. Adenomas are tumors of the glandular epithelium. A melanoma is a tumor of the pigmented skin cells, etc. So that's it for the names. There are many names of tumors, but there's some logic behind it. Now we turn to diagnosis and staging of tumors by physician, because that reflects the growth. The first thing in diagnosis and staging, what brings a patient to the doctor, are signs and symptoms. The signs might include things like a lump that they feel, or an ulcer that doesn't heal, or blood loss that's happening, or a swelling somewhere. Those are physical manifestations called signs. Symptoms might be things like malaise, you're just not feeling right, fatigue, you're tired, unexplained anorexia or weight loss, a period of multiple pounds over a couple of weeks or so, pain you can't figure out. This can be due to, you can have symptoms of organ failure. For example, the prostate cancer, as many people know, if the prostate swells in men, it can prevent urination. So the person comes to the doc with these signs and symptoms. And the doctor says, okay, now we want to do a diagnosis. First thing to do is clinical exam of the patient, right? And to say, okay, let's do a careful exam. And then after a clinical exam, we might see something important is to do imaging or a biopsy or blood tests for markers. In some cancers, you can begin a diagnosis just by observation. So for example, in melanoma, in skin, the melanoma of the skin, which is a serious tumor, this is called the ABCD symptom. A good dermatologist or even a general practitioner should know this. To look at a tumor, the ABCD system says if this pigmented skin lesion has asymmetry, doesn't have a nice round border, irregular borders, that's B, it has color variegation, that's C, different colors of darkness, and a diameter of greater than 6 millimeters, it might be a melanoma. It doesn't prove it, but it might be. A doctor will do palpation, right, to do feel an organ, the breast, for example, or they'll do a prostate exam in men. Then, of course, there are things where you can look for cancer internally if it's appropriate. X-rays, MRIs, CTs. For example, here are a couple of examples of that. Colonoscopy. Camera essentially is inserted into the colon and looks and can find colon cancer there. There's a photograph from a colonoscopy of a colon cancer. Mammography is a low-dose X-ray that can find small tumors up to a certain size in the breast. So once you have this observational ideas and observations, then you can suspect it to be cancer. You have to examine the cells. I mentioned in the last lecture. That's how diagnosis is done. A pathologist examines the cells and sees what the cells are like. Now, many diseases mimic cancer. You can get inflammation, lots of things. So really, looking at the cells is a way to make sure. How are you going to get the cells? A couple of different ways. You can get a biopsy of cancer by doing surgery. That is by putting you can do it laparoscopically, just a small incision, putting in take a small piece of the lesion out, which is the lesion meaning the mass of cells, and look at it in a microscope. There's something called exfoliative analysis, which would be tumors that are kind of sloughed off, that get off into, that are easily removed, like a pap smear, where you just take a small cells that are just floating on the surface of the uterine cervix, or body fluids, like I mentioned, a fluid in the lung that happens in lung cancer, or blood, for example, for blood cancer. You do a fine needle aspiration through the body wall, looking for, and then look at the cells, and the pathologist will look at the cells and say, do they look cancerous? At this point, in some cases, you can actually make a diagnosis. For example, here are cells of a normal versus cancer, cervical cancer, at a pap smear. You can see that the cancer cells look really, really different. But many cells kind of look normal in many instances in a biopsy. And so if the cell looks normal, you've got to look inside the cell, right? And sometimes you can do it with specific dyes for markers in the cell, but other times you've got to look for other kind of cell contents that the cells may have. Now sometimes as tumors grow, they release into the blood chemicals. And those chemicals, as tumors grow, might be tumor markers called biomarkers. What are these chemicals? They might be proteins or hormones that the tumor is making, and sometimes they can aid in a tumor diagnosis. So here is how this happens. The tumor is growing and they're near a blood supply. They release these markers. Very often healthy cells might release them too. This table shows some of the the tumor markers in blood that people use. Give you an example. CA-125 is used in ovarian cancer as a marker. Prostate-specific antigen, PSA, has been used for prostate cancer. CEA for colon cancer. HCG for testicular cancer. Of the 4 on my list, which are very common tumor markers, they are also markers of inflamed organs. So a normal prostate that just happens to be growing, that's not cancerous, will pour out PSA as well. A normal colon and inflammation in some inflammatory colon diseases, bowel disease, will form carcinoembryonic antigen. So just looking at the tumor marker is, of course, not enough. It's just an aid. Interestingly enough, the 4th one, human chorionic gonadotrophin, is actually the pregnancy hormone made in women, and the only time men will make it, the only time, is in testicular cancer. Now, more recently, people have started using molecular markers, looking for the tumor itself. So they'll do a biopsy, and then they'll look inside the biopsy for certain things that are molecular, DNA changes. For example, you recall Kareem Abdul-Jabbar, the basketball player in the opening story of the course, looking for this chromosome change. Remember the swapping of chromosome changes. As we learn more about specific details of cancer, we're learning more about tumor markers. So here is an example of a molecular marker of the epidermal growth factor receptor. This is a molecule on the outside of a cell. And here is a tumor that has low levels of it. Here's a tumor that has high levels of it. And this has great prognostic significance. It's a worse prognosis in that instance. So this is because you're going to get more cell division. Here's another example called a gene expression signature. Now we're looking at expression of genes. And you can take tumors, for example, in this instance, a pathologist sees two tumors here, and they look exactly the same. This is a large a B-cell lymphoma. For all intents and purposes, the physician will say that's the same. But there are some tumors that have a bad prognosis and others have a better prognosis. And you're going to make a treatment decision on the basis of that. You may not want to treat a patient with a good prognosis, a non-metastatic tumor, with aggressive therapy. On the other hand, you may want to do it with a poor prognosis. And so what people do is they look at all the genes that are expressed. You can do this now with highfalutin new molecular biology techniques. And molecular diagnosis in this instance sees two very different tumors on the basis of these molecular signatures of which genes are being expressed. You can actually look at all 24,000 human genes and see the levels of expression. For breast cancer, you can do this now, called the MammaPrint. After surgery, removal of the tumor, the question is are there metastases out there? And the tumor cells may tell you that, even though they look the same in a metastatic or non-metastatic tumor, inside at the gene expression level, they look different. And so you can make treatment decisions on that basis. Ultimate biomarker, of course, is DNA. And people are sequencing now DNA sequence of entire tumors. The issue here is, so we see DNA changes. We see mutations in tumors. Which ones are important for tumor development and which ones are not? We call them drivers, important for tumor formation. Passengers, not. Remember the stem cell idea of they might have a lot of driver mutations and not so many passengers. Tumors may be heterogeneous with different mutations in different cells. You know, ultimately, we're kind of moving toward a classification of tumors, not on the basis of what pathologists used to do, looking under the microscope, seeing, oh, that looks like a certain type of tumor. In the case of the graphic that's up here now, it's a lymphoma, and we're looking at this. No, they might start classifying them on the basis of molecular markers. An example of this might be this person. This is Hubert Humphrey. He was the president of the United States. He was the vice president of the United States in the 1960s. He had urinary symptoms in the 1960s, early 1960s, when he was a U.S. Senator from Minnesota. Looking at the urinary bladder at the time and cells in the urine, they seemed normal. In 1973, he got a bladder cancer diagnosis, and by that time it was pretty late in the game, and he died sadly in 1978. Now, he was treated at hospitals in Washington, D.C., and National Institutes of Health, etc. And so they have archived specimens. They have specimens of his tumor, and they still have the blood supply and the early biopsies that were done in the 1960s. And when they looked at the specimens, the tumor specimen at the time of death, it had a p53 mutation. It had definite DNA change. And when they looked at the early cells, it had they had the DNA change as well. And so at a time when the physician said, oh, looks normal to me, inside that cell was already the DNA changed for cancer. So we might have started with therapy earlier on. So that's a sad example, but it gives you the idea that diagnosis can be done using molecular markers. The next is staging. Staging is done after diagnosis, and it tells how far advanced the tumor is. And there's a system called the TNM system. T stands for tumor, N stands for the lymph nodes near the tumor, whether they have tumor cells, and M is metastases. M is either 0, they got metastases, or don't have them, or 1, there are metastases. Something about the lymph nodes. Here's a graphic showing lymph nodes around the colon. And so you see them all here. There are many, many lymph nodes. And so a physician will look at the tumor and then take samples of the lymph nodes going away from the tumor to see whether they have nodes there. Here's an example of staging in a tumor. It's for colorectal cancer, colon cancer. Stage 0 is a tumor that's just in the surface of the colon. Stage 1, it's invading. Stage 2, it's more invading. Stage 3, more invasion into the wall of the colon. And stage 4, it's breaking through and it's going to go to other organs. So that's the T part, right? The T part says how far has it progressed, burrowing into in a carcinoma, burrowing into the tissue. The N part is how many lymph nodes are there with tumor in them. And the M part is metastases. If you look at survival by stage, for this tumor, for example, here's a Kaplan-Meier curve, survival over here, and time after the colon cancer was removed. Stage 1 has good survival. Stage 4, of course, very poor. So the more the tumor has burrowed in, the worse it is. And of course, the M for metastases means that if there are metastases present, the only way you can treat it is chemotherapy. And in general, for tumors in adults, in general, if there are metastases, the person is going to die of the disease. It is incurable at that point. A second type of analysis doctors do at this stage is tumor grading. What you do is you look at the biopsy, you say how many cells are dividing, how differentiated is the tissue. So that's two different things, right? Differentiated cells don't divide. And so what they will do is make a grade. Grade 1 means highly differentiated, not dividing very much. Grade 3 means poorly differentiated, dividing a lot. And as you see from here in the Kaplan-Meier curve, patient survival versus years, a grade 3 tumor has much worse survival than a grade 1. So staging and grading can give an idea of what's going to happen with a tumor and whether treatment should be aggressive or not. The growth of tumors. So we've got the tumor started, we've staged it, and now what happens? How can we predict what's going to happen? The early growth of tumors is very hard to study. They're pretty small, right? But we have pretty good data from cervical cancer and lung cancer of the growth of tumors. Some tumors grow very, very slowly. Cervical cancer is one of them. Lung cancer actually is another. They are called indolent, well, maybe lazy. Lazy tumors, indolent tumors. They can take years to develop clinical significance. So it's kind of like the tumor is small and small. You're walking around, nothing's happening to you. You don't know you have it. It's not a pleasant thing to think about. And then the tumor gets big. And then one day, the tumor gets big enough to impact your intestine or something like this. You say, oh, I got a stomachache. And then they find this tumor that's been growing for 10 years. Others grow very quickly, like melanoma is an example, or some forms of pancreatic cancer. They can grow very fast. And from the time of initiation can be weeks until it's highly metastatic and very harmful. If you plot tumor growth on a graph, and this has been done for some human tumors, and there's a lot of work on animals as well. You can plot cell number over weeks of growth for a tumor. You get different plots for different tumors, of course. Some of them are rapid, some of them are slow. You have an early phase that's a logarithmic phase. So we're going 1 cell, 2 cells, 4, 8, 16, 32, 64. How long do the tumor cells, how often is a tumor cell dividing? Sometimes 12 to 18 hours, let's say. So typical a doubling time will be 18 maybe hours, or around a day or something like this. So it goes 1, 2, 4, 8, 16, 32, 64, 128, 256. Right, the tumor is growing and growing and growing and growing and growing. So at a small tumor, it's growing very rapidly. But normally, when the tumor gets rather large, it stops growing rapidly. There's still tumor growth going on, but there's also programmed cell death. So cells are being born and cells are dying, and the tumor is still growing inexorably. If tumors grew at the same rate always, the doubling time for a 50-cell tumor to 100 would be the same as a doubling time or a 5 million cell tumor to a 10 million cell. It's not so. Most tumors just kind of slow down as they grow. There's a problem with this. As you will see, cancer therapy is primarily based on rapidly growing cells. So if you've got a population of cells that are slowly growing, they may be able to repair some of the damage chemotherapy does. And that's why tumors are a challenge in terms of their growth rate. Summary. In this lecture, I've introduced tumor growth to you. We've talked about tumors being benign or malignant, what the differences are. I talked about the diagnosis and staging of tumors, how we name tumors, how they're diagnosed, from signs and symptoms to diagnosis and tumor markers, and staging, where the tumor is, and grading as well. How aggressive is the tumor? Then I talked about the growth in general of tumors. In the next lecture, I'm going to turn to metastasis, which is the most dreaded aspect of cancer as it spreads throughout the body, and angiogenesis, how tumors recruit their blood supply. And finally, talk about the burden tumors have on the functioning of the human body. Thank you.